Hi guys, welcome back. The topic we are studying now is thalassemia. And first of all, I would like to highlight the physical appearance of this patient. If you look at this image, you will notice that the malar eminences of this child are very, very prominent, just like this fictional character that I've shown here. Even the incisor teeth of the child are anteriorly placed, and they might be a bit of frontal bossing, though you read about frontal bossing even in rickets, in cases of gigantism, acromegaly. So I'll not like to focus on the frontal bossing component, but yeah, the malar eminences part is very prominent, and most of the time in these cases, because of the malar growth, you also have the nostrils of these patients. Like in you and me, the nostrils are opening inferiorly. In this case, the nostrils might be anteriorly placed as well. So therefore, the characteristic term that we use to describe this physical appearance in a case of thalassemia and will be helpful in solving the questions on this topic would be chipmunk faces. Reason why chipmunk faces would develop is due to the possibility of bone marrow expansion that will occur in this case, because you see the bone marrow is frustrated. It is producing RBCs. The amount of RBCs produced is normal, but the quality is bad because there's a defect in the globin component of hemoglobin. And let me now explain to you that what is the genetics responsible for development of beta thalassemia. This is an autosomal recessive condition, so 25% chances of expression in the next generation. The chromosome in which this problem would occur would be chromosome number 11, and the gene, well, that would be called as HBB gene. We also have now capability to do gene sequencing, which would help us in identifying this condition. So we can diagnose this condition not only with help of high performance liquid chromatography, but with gene sequencing, we can give more credibility to the diagnosis. Sometimes in genetics, they might even ask you what is the mutation present here. So there are two of them. In a multiple choice question, if they have to select multiple answers, cool. Otherwise, the single best answer would be the word missense mutation. If, however, it is not given in the options, then the second best answer would be nonsense mutation. To explain the disease process further, I would like to rather give some baseline information now with respect to hemoglobin electrophoresis, which can be done in you and me as of now, and we'll compare it with that of a child and then with respect to a thalassemia patient. If I do hemoglobin electrophoresis of myself or any one of you, there would be three major hemoglobins that would be demonstrated, which is fetal hemoglobin, adult hemoglobin, and hemoglobin A2. The day we were born, on the first day of our life, the major predominant hemoglobin in your and my body was fetal hemoglobin. Hemoglobin A was a mere 2% and hemoglobin A2 was 3%. This was the status on the day we were born. But subsequently, as we all grew up, like if I said, if I do it today in you and me, then fetal hemoglobin values will definitely be changed. In you and me as of today, as adults, there would be fetal hemoglobin value of 2%, but hemoglobin A will skyrocket to 95%. So you can see a tremendous increase in the requirement of the alpha chains as well as the beta chains, because that's the formula that you need to remember for the globin component here. And because if beta chain is missing, we call it beta thalassemia. If there's a deficiency of production of alpha chains, we call it alpha thalassemia. And this disease is prevalent all over the world, especially in North India. We do have is a relatively more common prevalence of beta thalassemia. Hemoglobin A2 remains constant at approximately 3%. We will understand the significance of that also, because when I will talk about thalassemia trait, then I will again talk about hemoglobin electrophoresis values of HbA2 more than 3%, though more information about trait will follow. But I just said the MCQ statement. If you read a question that says HbA2 values in a patient is more than 3% and other values are almost normal corresponding to age, that tells you that we are talking about a thalassemia trait. This adult value per se was obtained in you and me. Remember my statement. The adult value, which is currently in you and me, was obtained by approximately 6 months of age. Now from this baseline information, I simply wanted to highlight the tremendous increase in the requirement of beta chains as we move towards adulthood. And if the synthesis of beta chains is defective, well, we would be having defective RBCs produced. So in beta thalassemia major, the RBCs will be having only alpha chains. In fact, they would be alpha 4 tetramers. The alpha chains will coil among themselves because beta chain supply is not there. And therefore, these abnormal cells are going to be destroyed in the bone marrow, they're going to be destroyed in the spleen, and we will have severe anemia because bone marrow is doing all the hard work, but the results are not being obtained. So we also read the word ineffective erythropoiesis. I repeat that again. You see, the bone marrow is doing all the hard work. No results. We call it ineffective erythropoiesis. Few more baseline data. Like if they ask you which is the first hemoglobin to be formed in the body of an embryo, then first hemoglobin synthesis that occurs, or first hemoglobin to develop, should be answered not as fetal hemoglobin, which I find couple of guys casually answering. Yes, you all know that from physiology that the first hemoglobin to develop is GAVR1. After GAVR1 would be GAVR2, then would be Portland. So that's the sequence. And then subsequently by 14 weeks of gestation is when fetal hemoglobin will definitely make its appearance. Please remember the fact that hematopoiesis per se can start in the yolk sac as early as 2 weeks of gestation. In fact, a couple of aspects that I'm saying here, you would have read them even in physiology and in pathology. So a lot of information on this slide might actually be a revision of yours from basic sciences. Hematopoiesis begins in the yolk sac as early as 2 weeks of gestation, and the hemoglobins that are formed are what I just explained to you, that is GAVR1, then GAVR2, and then Portland. So they're basically embryonic hemoglobins. Subsequently, the hematopoiesis responsibility will be given to the liver and the spleen. So before we are born in a fetal life, it is liver and spleen which are responsible for producing the red blood cells. At approximately 14 weeks of gestation, one of the predominant hemoglobins that will start appearing, remember my words, the hemoglobin that will start appearing will be fetal hemoglobin, but fetal hemoglobin values will be maximum at the time of birth. So at birth, if they ask you which is the major hemoglobin, as you can see I've written 95% at birth would be fetal hemoglobin only. Subsequently, the responsibility will be given to the bone marrow. Well, at the time of delivery, like I can say by 36 to 38 weeks, it is hemoglobin A that will begin to appear. I'm not saying that hemoglobin A is the major hemoglobin at 36 weeks. It begins to appear. Similarly, fetal hemoglobin begins to appear by something like 14 weeks. So max hemoglobin at birth is going to be fetal hemoglobin. And when it comes to the bone marrow per se, which is responsible for hematopoiesis, which bones in the body of a baby are responsible for hematopoiesis? Like I show you a newborn baby today and he is having RBC synthesis. So which cells are going to be responsible? Well, the cells that are going to be responsible are obviously the cells in the bone marrow, but well, which are the sites? The sites are going to be the skull, then can be vertebra, then can be ribs. So gradually as we grow older, the hematopoiesis tends to shift towards the flat bones and the long bones. But I basically want you to remember that when it comes to a little baby, all bones in the body, remember my words, when it comes to a little baby, all bones in the body are involved in the process of hematopoiesis. And as we grow older, the hematopoiesis will shift distally. That is from the skull onwards, it's moving towards the peripheral sites. And if they ask you after 18 years of age, in fact, that's a biology question, which bones in the body are mainly responsible for hematopoiesis, then the answer is not long bones, guys. It is flat bones, which are one of the important sites of hematopoiesis as we grow older. Well, why am I teaching you this is because you see, because even skull is a site of hematopoiesis in a baby. That is why in beta thalassemia, there is going to be expansion of the bone marrow of the skull also. That is why there's going to be malar eminences that would be developing, because the first query of most doctors is that, sir, if hematopoiesis occurs in the bone marrow in the flat bones, then changes should be reflected in the fat bones. Why the face is getting involved? The face is getting involved because even the malar bones are involved in hematopoiesis. And therefore, in a little baby, they'll expand because, as I explained, this disease is a disease of the quality of the globin that is being produced, which is miserable in a sense that defective RBCs are being produced. Amount-wise, no problems. Quality-wise, big problem. And these RBCs are going to be busted. They're going to be destroyed by the bone marrow itself, because bone marrow is doing that I'm doing a wrong thing. You know, आपको mind में पता है गलत काम कर रहे हो, तो then गलत काम कर रहे हो तो फिर आदमी कहता छोड़ यार ये तो खराब हो गया. So similarly here, the bone marrow is doing the hard work, but then the results are not being obtained. So there's a frustration, and therefore bone marrow expansion occurs in these patients, which results in very characteristic manifestations. Though I have explained the major aspects of the disease already, let me just jot them down for you. First on the agenda would be to talk about beta thalassemia major. Well, when you read the word major, it basically means that there is 0% production. The genes involved in synthesis of the beta chains are not doing their job. There is a 0% production of the beta chains. Therefore, the alpha chains will coil among themselves to form what we call as alpha 4 tetramers, and the red blood cells are anyway defective in this particular case. Let me say horizontally, if this is the representation of the bone marrow and this is an alpha 4 tetramer containing red blood cell that is synthesized, first and the foremost, this cell will be destroyed in the bone marrow itself, because bone marrow knows that it has done faulty job, so it's gonna try and destroy it. So you will read in pathology the term ineffective erythropoiesis. Even if some of these cells will escape out of the bone marrow into the peripheral circulation, the spleen is not going to leave them. The spleen will destroy them. In you and me, the spleen is going to destroy red blood cells at about 120 days. That's the expiry period. When it comes to a little baby, it might be a little lesser, about 100 days or so. Fetal RBCs, they tend to live a relatively shorter period of 100 days. But the point is, in this condition, these defective RBCs are going to be destroyed in the spleen. This RBC was produced, let me say, 1 hour back. When it goes through the systemic circulation, obviously through the spleen is going to rip it apart, and therefore you would be having a extravascular hemolysis occurring in this patient. The hemolysis speed is much faster as compared to you and me because of 2 reasons. One, most of the RBCs are getting destroyed in the bone marrow, and the ones that escape and come in the peripheral circulation are destroyed by the spleen. Therefore, babies of thalassemia major will present before 1 year of age with anemia so severe that these kids will go into congestive heart failure. I have seen cases of little babies who have been diagnosed with severe anemia, and lots of time, we might think it is iron deficiency anemia because that's what we commonly study in pediatrics, that you see cow milk fed babies tend to develop iron deficiency anemia. So you always need to have a high index of suspicion every time you see an anemic infant. Don't only think in terms of iron deficiency anemia, because I agree that in India iron deficiency is very prevalent, and in India maybe formula feed and cow milk feeding might be given to the child in poor families, and along with that you always need to check for organomegaly. Along with this, you will also notice that the bone marrow in this case will get frustrated, as I highlighted. So by these arrows, I'm just trying to say there's a bone marrow expansion in this case. This explains the chipmunk facies that occurs in these patients, and as they will grow older and when the teeth would come out, the incisor teeth will be relatively more prominent. The third statement is of very interesting for this particular topic, that bone marrow is frustrated, so it has now given up. He says, "Main to nahi kar paunga." So now the body will give the responsibility for hematopoiesis to the liver and the spleen. You see, if you're listening to me carefully, I had told you that before the baby is born, hematopoiesis responsibility can be in the liver and the spleen. So now the liver and the spleen will try to do their job, but obviously they won't be able to do much because there is no supply of the beta chain. So because there is extra responsibility on the liver and the spleen also, so there would be a hepatosplenomegaly developing in the patient. In fact, in this condition, spleen will have to do 2 things. First, it will produce defective RBCs. There's no supply, right? So it will also produce defective RBCs like bone marrow. So the spleen will first produce defective RBCs and then will have to destroy the same defective RBCs. So double the work, no? First, it does production much more than normal, right? It tries to. It's not going to be able to deliver the results, and then it will have to destroy those also, because after all, those defective RBCs will get trapped in the splenic sinusoids and they rupture. Therefore, in this condition, because spleen is doing double the work, the size of the spleen may actually overtake the size of the liver, and therefore the manifestation that could be written in the MCQ can be splenohepatomegaly. Well, you might argue with me, sir, what is the difference? Hepatosplenomegaly, you could have said. No, hepatosplenomegaly basically fundamentally means liver is bigger than the spleen. When I say splenohepatomegaly, it basically means spleen is bigger than the liver. And why is the spleen bigger than the liver? Is because the spleen is doing double the job. It's one, producing more. Second, it is also destroying the same RBCs at an accelerated rate. So the size of the spleen overtakes the size of the liver, and this is technically taught in pathology as EMH, that is extramedullary, as you can see outside the bone marrow. Hematopoiesis, it's obviously going to be faulty. I mean, it's not that bone marrow will be not able to deliver and liver and spleen are going to deliver. That's not going to happen. So EMH is always going to have a splenohepatomegaly present. In fact, that's an important terminology that you need to remember, because even when you study myelofibrosis, even in myelofibrosis, we read about extramedullary hematopoiesis, and there also it is written splenohepatomegaly. So the diagnosis of this condition is pretty straightforward. A severely anemic child, so bad that he goes into heart failure. Due to heart failure, he might even have a hepatomegaly that might be exaggerated. There might be anasarca, overall swelling of the body of the child, but you need to pick up the spleen, you need to pick up the facies. Now, facies are something that may not be picked up in a small baby. But then a large spleen would always tell you that it is a hemolytic anemia that is the troublemaker in this particular case. We shall now be comparing the manifestations with thalassemia intermedia. As the name suggests, the manifestations will be relatively milder, but let us see why. You see, in this condition, thalassemia intermedia, approximately 50% production of beta chains is there. So, because I'm saying at least 50% production of beta chains is there, some of the RBCs at least will be normal. Therefore, in this condition, the age of presentation is after 1 year of age. The child will definitely be having anemia, but it may not be so bad that it will cause heart failure. Splenohepatomegaly would still be present. Splenohepatomegaly would still be present. Chipmunk faces would still be present. All I'm trying to say is that because at least some supply of beta chains is present in this case, as a result, the manifestations are milder and the age of presentation is relatively a little later. In contrast, when it comes to thalassemia minor, you will say that the patients are asymptomatic. In thalassemia minor or thalassemia trait, I can say almost 90% supply of the beta chains is very much there. So since majority of supply is there, I said majority of cases are asymptomatic. They might be having a relatively lower hemoglobin and a microcytic hypochromic anemia. So lots of time patients with thalassemia trait might be misdiagnosed as iron deficiency anemia, and a doctor might start iron supplementation without getting serum ferritin and other iron studies done. You will notice there would be no improvement in the hemoglobin of the patient. In fact, patient will himself say, sir, I've taken iron supplements for so long. Normally iron supplementation is given for 6 months. At least there should be some rise of hemoglobin. In this particular case, there would be no rise in the values of hemoglobin of this person. So most patients are anemic with microcytic hypochromic anemia. It's a misdiagnosis that can definitely be seen. Therefore, I today have a patient who has been anemic and has been taking iron supplements for long duration. He says, sir, my hemoglobin is not rising. So I would suggest a test to this guy that is called as naked eye, single tube, osmotic fragility test. And you can definitely see the image on the slide at the moment. When it comes to thalassemia, you need to remember that the osmotic fragility is reduced, whereas in hereditary spherocytosis, that I will talk about subsequently because the RBCs are smaller, they tend to burst easily. So in hereditary spherocytosis, we say osmotic fragility is increased or enhanced because RBCs burst easily. Here, rather, you will say osmotic fragility is reduced. Well, this test is subject to bias because you can see a control where you can see a test tube with two lines being seen posteriorly. On the other hand, in the tube, which is showing a positive test, you can see that no lines are being visualized. The problem with naked eye single tube osmotic fragility test is that it is subject to bias. Therefore, it's always a good idea to do a hemoglobin electrophoresis to identify thalassemia minor, and if HbA2 values are more than 3%, that gives more credibility to the diagnosis that we are dealing with the case of thalassemia minor per se. Now, I can explain this particular domain in a different way also. Suppose today you have a educated couple who have come to you. The boy is a Punjabi, the girl is, let me say, Gujarati. Intercaste marriage is what I'm saying. Now, as people are becoming more aware. In case of intercaste marriage, this girl or this boy, one of them, he or she says that my cousin brother had a baby and he was diagnosed with thalassemia. So I just want to know that are we also carrying something in our genes that we might transmit it to our baby? Like the girl says, I saw my cousin sister struggling with this baby with thalassemia. I just want to know whether I am carrying an abnormal gene in my body and I might have a baby like this. So I can definitely do the same tests in this girl Nestrov, both in boy and girl, to determine the presentation of the trait, because anyway, they could be having a baby with thalassemia because it is running in the genes of this family. There's another way you could actually diagnose whether the baby is having the manifestations or not. Like suppose they are married, right? And she's already pregnant and she says, sir, I just want to know whether my baby will be having thalassemia or not. So I said two things. One is a prenatal counseling, right? That's going to be like in a sense that if a couple is unmarried and they're saying that, okay, we want to know whether we're carrying the trait or not, you could do a Nestrov and a HbA2 values. But if she's already pregnant, then instead of testing two of them, yes, I can test both of them. But the point is, I want to now know whether the baby that she's carrying is having the problem or not. So the test that I can do for prenatal diagnosis of thalassemia is chorionic villi sampling. As you're aware, chorionic villi sampling can be done relatively earlier. So therefore, you will have a diagnosis relatively earlier. And as a result of it, you can, if it's abnormality, you can do an abortion also early. You see, doing an abortion in second trimester is always more risky as compared to doing abortion in the first trimester, because amniocentesis is best done between 16 to 20 weeks approximately. So therefore, even if you get the bad news that the baby is having thalassemia, you would be doing the abortion in the second trimester. You see, a lady has a right to be aware of the fact that the baby that she's carrying is totally fine. So there are two domains that I have said here before you. One is the concept of genetic counseling. A couple comes to you, says we want to know whether we are going to have a baby with thalassemia because my cousin had a baby like that. You can do the test that I've highlighted with the tick mark. But if she is already conceived, or the situation of conception is given in the question, then the answer should be given as chorionic villus sampling followed by amniocentesis. Osmotic fragility test is, yes, a screening test that can help you in identification, but then it is subject to bias. And if you are going to run a peripheral smear in these patients, you will definitely be able to pick up some abnormality in the following sense. You see, normally when you see a red blood cell, I'll just use a pink color to highlight it. If you see a red blood cell will always be having a central pallor. In this particular case, you will notice that one, the RBC will be relatively smaller, and inside that a dot will also be seen. Like you can see a large number of cells with these dots in between. This dot is because of the alpha 4 tetramer component. So the cell that I've highlighted here before you is called as target cell, and that definitely helps you in making a diagnosis. Though target cells are also read in literature of chronic liver disease apart from thalassemia. But yeah, I mean, if he gives you a peripheral smear like this, which has been given up to a number of times in the exam, I mean, this is a slide that you just need to have imprinted in your brain. You can see the target cells present at a large number of places. So at 12 o'clock, then maybe at 1 o'clock, 2 o'clock. I mean, everywhere in the slide, I can just put a pointer and I'll find the target cells in this case. As a result of it, I think that personally speaking, the way the question is framed for thalassemia, it is very hard to miss out on the diagnosis of this condition. We will now talk about what are we gonna do for the workup of this child. So lots of time questions on investigations part are asked. You see, in any anemic child, we are anyway gonna go in for hemoglobin, and then we're gonna evaluate the peripheral smear for the type of anemia. The pathologist will tell you that this is going to be a microcytic hypochromic anemia with classical target cells demonstrated. But because microcytic hypochromic anemia and target cells can be seen in other conditions also, so you really can't be sure at the moment. Therefore, I will be getting a reticulocyte count done in these patients. Now, I want you to listen to my next information very carefully. The reticulocyte count is always increased in all hemolytic anemias, no doubt about it. I mean, we always read reticulocytosis is the hallmark laboratory feature of hemolytic anemia. But when it comes to thalassemia major, listen to my words with care because you might miss out some terminologies there. You see, in thalassemia major, reticulocytosis occurs, but the rise is lower compared to the severity of anemia. Please mark my words. I'm not saying that the values are lesser. I'm not saying there is a reticulocytopenia. What I'm saying is the reticulocytosis is occurring, but the magnitude of reticulocytosis is lesser. The rise is lower as compared to the severity of anemia. You see, when I describe this lots of time, the impression that might be carried to you while listening to this is that I'm saying reticulocyte count is lesser. I'm not saying it is lesser than normal. I'm saying it is still rising, but it is not rising proportionately. The statement is rise lower as compared to severity of anemia. So that statement of mine should definitely be taken in the right perspective. I never said lesser. I just said the rise is going to be not the way it should happen. Then I can do a naked eye single tube RBC osmotic fragility test. The report of this will definitely turn out to be that the osmotic fragility is reduced. And now we come to the investigation of choice for this condition. You see, when it comes to investigation of choice, it is still a high performance liquid chromatography. I mean, the best way is HPLC for this condition. What he's saying nowadays is that along with this, you can also do beta globin gene sequencing. The gene that I'm talking about is going to be HBB gene. So do remember, we can also do a PCR, or even if I don't do a PCR, I can just say that if he writes this word, right, beta globin gene sequencing, yes, it is a supplementary test. I'll tell you the reason why we are doing it also. But beta globin gene sequencing is also a very good test for identification of this condition. If both are given in the question, you need to select both, as has happened in the AIMS exam where multiple are correct, or in the recently concluded INISET November 2020. Both of these were tests that are to be done. If you have to answer only one, right? If you have to answer only one, then obviously genetic evaluation will always be superior as compared to the HPLC. Now, why am I saying this is because of this statement from the textbook. I'll just show you a snapshot that will make you more comfortable with what I'm saying. I'll zoom it before you, and you will be able to then appreciate my terms relatively better. So let's have a look at it. He has mentioned this in the textbook that the genetic sequencing can be used to identify hemoglobin variants, like you read in pathology, like beta plus and beta zero. So he says that more you get into, the summary of mine is, more you get into genetics, more you get into the abnormal types of hemoglobin variants, you would be able to get a much more precise diagnosis. So he says that this gene sequencing is able to identify hyper unstable hemoglobin variants. He also says that as such, the results of this test should always be interpreted with context of protein studies and RBC indices. So he's saying that do not rely on HBB sequencing alone. It is supplementary. It's not a primary test. It's a supplementary test. But you can definitely add this to the literature, in a sense that along with HPLC, if you are doing this particular test that I've just highlighted, then you are giving more credibility to your diagnosis. The next thing that he loves to talk about is radiological studies with respect to thalassemia. The moment we read about radiological aspects of thalassemia, the first thing that comes to our mind is crew-cut appearance. But he knows that because you are aware of crew-cut appearance, he would definitely love to quiz you not about X-ray skull finding, but rather about a X-ray hand finding. Here I'm trying to represent a metacarpal bone. A metacarpal bone might look like a dumbbell, a proxy. But because there is an expansion of the bone marrow, as I told you, in babies, all bones in the body are involved in hematopoiesis. So even the bone marrow of the metacarpal bone is expanding, because of which you will notice that in this particular case, the metacarpal will look a little different from what it originally should. The technical term I want to highlight, and this radiological finding is gonna develop earlier than the crew-cut appearance. This radiological finding is called as squaring of the metacarpals. So lots of time, because crew-cut appearance is a piece of cake for you. I mean, you can just answer it even when you are awakened from sleep and asked, okay, where do you get crew-cut appearance? Thalassemia. So you also need to remember in the same spirit, the aspect of squaring of the metacarpals. And if you're going to do a X-ray skull in this case, then there is going to be widening of the diploic spaces. You see, in the skull, we have inner table, we have outer table. So in this case, what's going to happen is that there's going to be an expansion, and the trabeculations of the bone will look relatively more prominent. So what I've shown is that the diploic spaces are relatively increased, and the bone trabeculations are looking relatively more prominent, which explains what you can see in this particular image also. That is going to be a very characteristic crew-cut appearance. I'm going to dedicate next few minutes into describing various X-ray skulls that have been asked in the exam. So before we go into the treatment part for thalassemia, a bit of inputs regarding various X-ray skulls that have been asked, even with a history or without a history. Even if it is given without a history, in this image you can notice multiple lytic lesions which are having a very characteristic raindrop configuration. As you would have guessed it by this time, I am definitely talking about multiple myeloma. The topic is already discussed in the earlier section of the app. So when we talk about plasma cell disorders, there could be lytic lesions which are explained by expression of various cytokines which are liberated by the plasma cells, and therefore in spite of having a normal serum alkaline phosphatase, these lytic lesions would be present. I would then like you to focus on the X-ray of another patient slightly on the right side of this one, in which you can again notice a few isolated lytic lesions. At least two lytic lesions can be seen, but they're not having that classical small raindrop configuration. In this patient, the age is given to be 80 years of age. He's saying that this person has started recently developing frontal bossing. He has also started developing hearing issues. On the workup of this patient, serum alkaline phosphatase was found to be disproportionately elevated, and X-ray skull of the patient is given here. Well, in a geriatric population, because there's a deformity developing in the skull, even the cochlea is getting deformed, so there is a sensorineural hearing loss, disproportionate rate of SAP, and lytic lesions in the skull. The disease that we're talking about here is Paget's disease. So what they've done in the exam is they have given multiple myeloma X-ray skull for an old man, because multiple myeloma is again a geriatric disease, and so is the case of Paget's disease. So whenever you see lytic lesions, don't jump the gun and straight away answer as multiple myeloma. That's the carry home message, guys. Every time you see lytic lesions in the skull in an old man, don't jump the gun and straight away answer as multiple myeloma. myeloma. It could be Paget's also, so you need to read the clinical domain, because in multiple myeloma, features of CRAB would be given: hypercalcemia, renal failure, anemia, bony lytic lesions. I've explained that in multiple myeloma, but for Paget's also some clinical inputs have been provided. Next, I'm going to talk about a child. This particular child's X-ray was given, but you can notice that there is going to be rather lytic lesions in the skull. No crooked appearance at this moment, and the shape of these lytic lesions is very irregular, like maybe map of some country, right? I mean, this is looking like a map of a country. So the X-ray that I'm showing here before you is technically called as geographical skull. And by this time, I think you guessed it right. I'm talking about histiocytosis X. That's again very frequently asked MCQ. Child. So I've told you 2 X-rays for old man, 2 X-ray skulls for pediatric age group. Both the domains have to be remembered. And the 5th X-ray that I'm not showing a picture here, but I'm just telling you verbally is they can give you a X-ray of a skull in which there would be a lateral view given, right? In fact, I can put up as a question to you guys. In the exam, you're getting an X-ray skull lateral view, and at the area where the sella turcica is, like, this is the area where the pituitary would be present. In that particular area, there is, I'll just use gray color to highlight it, there is a lot of irregular calcification present in the area where the pituitary is supposed to be present, close to sella turcica. Well, I'm describing a brain tumor here that shows an intracranial calcification. The brain tumor that shows an intracranial calcification and is seen in children is called as craniopharyngioma. So in this particular slide, over and above thalassemia, I have compiled 5 scenarios for you for X-ray skull. There are 3 for children. Let me enumerate which are the 3 for children. I want you to be very clear about crooked, no issues. Then is going to be geographical skull, that is histiocytosis X, and then craniopharyngioma. In contrast, you can notice the fact that in the superior 2 that I've highlighted, it is old men, that is multiple myeloma having raindrop configuration, versus Paget's disease that is having a disproportionate rise of serum alkaline phosphatase. We shall now focus on the treatment aspects of thalassemia major. Well, the treatment of choice is allogenic bone marrow transplantation, but for that you need matching, you need financial support for the family, you need a facility for transport of the patient, and lots of things may not be available immediately. So initially, for survival of this child, I need to give packed RBC transfusions. Please remember, do not answer whole blood transfusions. I don't want to waste blood on this child, because in this kid, the problem is mainly with respect to the RBCs. When you will be giving RBCs to this child on a recurrent basis, they will go in the body of this child, definitely improve the hemoglobin values, definitely ensure growth of the child. But the bad news is that every RBC has a half-life, and this transfused RBC will ultimately also get destroyed. Well, what is the lifespan of a transfused RBC? You are aware of the fact that normal RBC can live up to 120 days, fetal RBC about 100 days, but transfused RBCs will live for 60 to 80 days. And in this case, there's a distinct possibility that as the spleen will become bigger, there can also be an additional problem of hypersplenism. Due to hypersplenism, the lifespan of the transfused RBC will decrease even substantially much more, and as a result of it, this child might be requiring a transfusion almost every 2 months or every 1.5 months. This means that a baby of thalassemia major will be requiring almost 8 to 12 transfusions a year. Therefore, I can highlight that these kids are transfusion dependent, and this also means that there would be some complications coming in, because you are sending in lots of iron in the body of this child. This transfusion dependency will result in overloading of iron in the body of the child, and therefore secondary hemochromatosis can develop. The extra iron can be deposited in multiple organs of the body. It could be deposited in the liver, resulting in liver cirrhosis. It could damage the beta cells of pancreas, causing type 1 diabetes mellitus, that is called as bronze diabetes, and it could be deposited in the skin, contributing to bronzing of the skin. I have spoken about bronze diabetes even in the endocrinology section, but today I'm trying to explain to you that why are you getting it? The reason for this is a transfusion dependent child who has developed iron toxicity. Yes, we can prevent it also by using iron chelators that I will speak about, but at the moment I wanted to highlight 2 aspects. One is development of bronze diabetes in these patients. Second, extra iron can also promote growth of a bacteria by the name of Yersinia enterocolitica. Now, why is he asking this is because he knows the fact that when you read hemolytic anemias like sickle cell anemia, in sickle cell anemia, there is an autosplenectomy. The moment the spleen is gone, there is going to be increased susceptibility to capsulated organisms, and that is going to be pneumococcus and meningococcus and haemophilus influenzae. So though you are aware of it, I'm just highlighting it in contrast. Please remember, in thalassemia we have a splenohepatomegaly, but in sickle cell anemia we have an autosplenectomy. That is where there is an increased incidence of infection with pneumococcus, meningococcus and haemophilus influenzae. But if he specifically says thalassemia, which bacteria will be having higher chances of causing problems in the form of sepsis, it's not capsulated organism, it's going to be Yersinia enterocolitica. This is an important question that I definitely want you to remember. Incidence of infection with Yersinia colitica is increased in patients with iron overload, in contrast to sickle cell anemia where capsulated organism incidence is more. Well, what can we do to prevent this hemochromatosis component? So we can be using iron chelators. There are many of them. There are oral ones available. There are obviously ones which can be given in the form of a subcutaneous infusion. So we can definitely use deferoxamine. You see, subcutaneous infusions are painful, or I would say not very comfortable. So parents are already distressed by bringing the child to the hospital so many times in a year for packed RBC transfusions, and over and above them, you ask them to stay extra for desferoxamine infusion, right? Because obviously you need to give an infusion, so it will take some time. Maybe one day extra of hospitalization. Parents may not be very compliant with this. That is why there's a need for oral drugs, but then they have their own side effects also. If in the exam he just asks you which is the best iron chelator, the first answer is obviously the parenteral one will obviously have a better response, no, so deferoxamine. But yeah, for compliance purposes, in case they don't, parents are working, poor family, don't have resources, then you might have to use oral iron chelators as well. The objective of the discussion is to sensitize you to the fact that in patients of thalassemia major, their own bone marrow is not doing anything perfect, in a sense that it is 0% production of the beta chains, which is the reason why you have to give RBCs from outside. But there is a limit. How much can you give? I mean, there could be complications of recurrent transfusions. There could be graft versus host disease. There could be allergic reactions. I've explained that even in the section of blood transfusion per se, or blood transfusion complications. Why I'm repeating that is because I want you to be sensitized that if we want to prevent graft versus host disease, if we want to prevent allergic reactions, we might have to use leukodepleted blood here. So lots of time, though this is given already in the blood transfusion complications part, I'm just highlighting, we might be using irradiated blood in this case if facilities are there. This is to reduce the chances of complications. So I'm talking about leukodepleted blood being given to the patient. That's going to be irradiated blood, or we might have to use a special filter. I have described various filters in the hemat section in the earlier lectures, which can actually stop the white blood cells, which are the villains which are responsible for the allergic reactions. And then over and above this, I can also say that sometimes you might read words like triple saline washed RBCs as well. That's again to reduce the allergic complications that might occur. Out of the three, irradiated blood, because filters are again expensive, they might get blocked. Irradiated blood is one short way that you can give leukodepleted blood to a patient, because after all, what is he requiring? He does not require white blood cells, guys. He requires red blood cells, which are defective, which are defectively produced in the bone marrow. So you provide what is actually required. The treatment of choice for these patients would be answered by you as allogenic bone marrow transplantation. Question to you guys, can you tell me hematological conditions where you read about autologous bone marrow transplantation? Looks surprising but true. Autologous. You normally read about skin transplantation and burns, no? Autologous bone marrow transplantation. Guys, I have talked about autologous bone marrow transplantation in the lecture of multiple myeloma, and is also recommended in cases of patients not responding to conventional chemotherapy in Hodgkin's and non-Hodgkin's lymphoma. This looks like a surprising statement when you read for the first time, because the query of most people is that he's already having a hematological malignancy. You are teaching us you want to take out the defective cells from the bone marrow and give it back to that guy. Well, there's a lot of science involved behind this. I've discussed that in multiple myeloma section, guys. It's not that you're removing the cancer cells from body of a patient and giving it back to him. You do a lot of technical processes there so that it is the normal cells. When you remove the cells, there will be cancer cells and normal cells also. I'm not gonna give cancer cells back into his body. I'm gonna kill them. It's the normal cells which are going to be sent back to colonize the bone marrow of this guy following a chemotherapy. So autologous bone marrow transplantation indication should also be known to you, obviously, and the main treatment for this chap is to go in for a allogenic bone marrow transplantation. Then you will also read about hypersplenism in these patients, and how do you know that the hypersplenism component is occurring? Because you see, spleen size is bigger. If the size of spleen is bigger, that cannot be used as a criteria to say it is hypersplenism. You need to demonstrate the voracious appetite of the spleen. The spleen is destroying the cells. So, to demonstrate that there is a hypersplenism component, if you find that the requirement of packed RBCs is increasing by more than 50% over the last year, you see, let me explain this mathematically. Suppose a child required, a thalassemia major child required, I'm just saying hypothetically, just for mathematical purposes, 6 transfusions in 1 year. 6 transfusions in 1 year. And let me say that was 2020. And in 2021, what is happening is that in 6 months, only 6 transfusions have been given. I mean, only half the year has passed. And already 6 transfusions have been given. That means that the spleen has a voracious appetite this time. It's destroying the RBCs, the white blood cells, and the platelets. So in case the transfusion dependency increases by 50% over the last 1 year, then we might have to proceed for elective splenectomy. Please remember, traditionally, elective splenectomy is done in very limited cases because you know that they might be increased susceptibility to capsulated organisms. Elective splenectomy will be discussed even in treatment of hereditary spherocytosis. Obviously, there are indications like splenic abscess. We might use it as a staging procedure in lymphomas. But then hereditary spherocytosis is one of the important conditions where we always talk about elective splenectomy being done in a patient. Another scenario where a splenectomy might be done is patients of chronic ITP. And then I've told you thalassemia major with increased transfusion dependency. And what I mean by quantification of increased transfusion dependency is increase in more than 50% of transfusion requirement over last 1 year. Like in last 1 year, 6 transfusions in 12 months. Now 6 transfusions in 6 months. So definitely the spleen appetite has increased, and I need to be planning out for elective splenectomy. When it comes to elective splenectomy, vaccination of the kid will also have to be done. Pneumococcal vaccine, then meningococcal vaccine, Haemophilus influenzae, and apart from this, even the influenza vaccines would be given to this child so that the chances of this child dying of sepsis is substantially reduced. I will now be comparing the information that I provided to you for beta thalassemia with that of alpha thalassemia. This is an autosomal recessive condition again, but this time the chromosome involved is chromosome number 16, and well, the genes involved this time are HBA1 gene and HBA2 genes. Once you get the names right from the genetics domain, I want you to remember the following table, which is the crux and is the only thing that is asked. I want you to remember that the formula for hemoglobin A was alpha 2 beta 2. That means there are 2 alpha chains, right? And there are 2 beta chains. I repeat that again. Alpha 2 beta 2 formula means 2 alpha 2 beta chains. For synthesis of these 2 alpha chains, that's the keyword, guys. There is requirement of 4 alpha genes. And for 2 beta chains, there is 2 beta genes required. I repeat that again. The numbers to be remembered are 4, 2 and 2, 2. For 2 beta chains, 2 genes. But for 2 alpha chains, you have 4 genes present, and if any one of genes is malfunctioning, like in this particular case, instead of writing alpha 4 times, which is 4 genes, I'm saying 1 gene is defective. It means that there will be approximately 70%, 75% production still available. As a result of it, the disease will remain clinically silent. So you will read about silent carrier in alpha thalassemia who's having almost 75% normal production occurring at alpha chains. As a result of it, well, the disease does not cause any problems for the patient. But if 2 genes are defective, it's going to be 50% production that is happening at the moment. The term that we use to describe this is called as alpha thalassemia trait. So you just need to get the figures right. At 75%, it's going to be called a silent carrier, 50% alpha thalassemia trait. But if it's going to be only 1 gene functioning, now there is only a 25% production available. This is where manifestations will start coming and would be called as hemoglobin H disease. This will be akin to thalassemia major occurring in a patient. Like I was describing, thalassemia major presents before 1 year. HbH disease would manifest in the same way. Suppose none of the genes are working, 0% production. That's gonna be really nasty, because now the hemoglobin that is formed here is actually called as hemoglobin Barts. From physiology, you are aware hemoglobin Barts will be written as gamma 4. It will have very high oxygen affinity. What I mean by that is that it will keep all the oxygen with itself. It's not going to give it to the tissues, and if oxygen will not be available to the tissues, the heart will fail, because heart needs oxygen to pump blood. In patients who are having the fourth variant that I'm trying to explain to you, that is hemoglobin Barts, the presentation will develop in fetal life. I want you to appreciate that in thalassemia major, the manifestations were after birth. But in alpha thalassemia, the most severe variety of alpha thalassemia can present even before birth also. I repeat that again. Beta thalassemia never presents in fetal life. It presents after the baby is born. But alpha thalassemia can present in fetal life also. How? The hemoglobin Barts is very selfish. It's gonna keep all the oxygen to itself. No oxygen availability to the tissue, especially to the heart. So because of deficiency of oxygen, the heart will begin to fail. Because the heart will begin to fail in this case, there would be a generalized swelling in the body of the baby. So I can use the word hydrops fetalis. Well, the bad news is a baby with hemoglobin Barts can actually die. I have explained to you in earlier discussions that immunogenic hydros fetalis is Rh incompatibility, because you see in Rh incompatibility antibodies will cause the damage, but this time I'm giving you an example of non-immunogenic hydrops fetalis where the baby will die even before he is born. The term non-immunogenic hydros fetalis has also been discussed earlier in our various lectures, so I'll just remind you. The first time I have described it is for a baby with congenital nephrotic syndrome. In fact, the version of congenital nephrotic syndrome that I described to you was called as Finnish variety. So you can go through the kidney section nephrotic syndrome where I have deliberated about it. The second condition is complete heart block. Well, complete heart block would again be causing low cardiac output and pulmonary edema, and the heart is failing, and therefore the baby will develop a swelling. Complete heart block has been described in newborn baby, in a baby born to mother with SLE and S. Sjogren. So in rheumatology, I have highlighted that a baby born to lady with SLE, S. Sjogren, neonatal lupus can definitely be due to anti-Ro antibodies and can cause a non-immunogenic hydros fetalis, and then can be congenital syphilis. And the fourth entry is the topic that we are studying, alpha thalassemia, the most severe variety called as hemoglobin Barts. When it comes to the topic of alpha thalassemia, they mostly ask about the details related to this table only, and they will usually ask you which is the most severe variety, which I've already highlighted. So I think it's relatively simpler. If they ask you what is the best test for diagnosis of alpha thalassemia, same way, it is HPLC, and we can go in for alpha gene sequencing also. We can definitely, we can do a gene sequencing. That would be one of the good ways to identify it. And at the same time, we can also do a naked eye single tube osmotic fragility test. So osmotic fragility will be reduced here also. The manifestations of beta and alpha thalassemia are same. The only thing is ethnicity might change. Like for example, in beta thalassemia, if I was talking about an Indian patient, in alpha thalassemia, I might be talking about a Vietnamese patient or maybe an Italian patient. It's just the ethnicity of the country of origin that will change. Otherwise, the basic manifestations are still going to remain the same. The next disease on the agenda is to talk about hereditary spherocytosis. Well, these cells will be having a relatively lesser surface area, so we will be doing a mathematical activity here. You see, MCHC is mean cell hemoglobin concentration, which is mean cell hemoglobin divided by mean cell volume. In this case, because the RBCs are smaller, the denominator is lesser, therefore this ratio will be increased. This happens to be one of the important diagnostic criteria for identification of hereditary spherocytosis. I'll explain the hereditary spherocytosis diagnostic criteria as we go along, but this is one of them. And now let's understand what's the real problem. Let us take this as a representation of a normal biconcave red blood cell. The total diameter of a red blood cell is approximately 7 microns, whereas the diameter of the capillaries is approximately 2 microns. So you can see that a 7 micron cell can travel through a 2 micron capillary. Well, how is that possible? It is possible because our red blood cells are highly flexible. They can actually fit in and squeeze through the small capillaries and move on. What gives such extreme amount of flexibility to the red blood cell? There are certain proteins which are present in the membrane of the RBC which will give extreme flexibility. The name of the proteins are spectrin, encheirin. Then you read about pallidin, Then is protein 4.2. While I'm writing them, I think everybody is familiar with the fact that if spectrin is deficient, the disease developing is hereditary elliptocytosis. But when it comes to ankyrin, it's mainly hereditary spherocytosis, the topic of interest. All these proteins that I've written before you are actually going to give a lot of flexibility to the red blood cell. But if any one of them is defective, like in this case, I'm putting a line over ankyrin to say that once ankyrin is not there, the infrastructure of the membrane is hampered, and therefore in this condition, the red blood cells will become extremely rigid and stiff. Well, if they're rigid and stiff, they will get stuck in the sinusoids of the spleen, and therefore in this condition, again, there will be extravascular hemolysis. I've given two examples of extravascular hemolysis to you in this particular discussion. One is thalassemia and second is hereditary spherocytosis. The bottom line is whenever hemolysis is occurring per se in the sphenic sinusoids, we always call it extravascular. Whereas if it's a complement mediated destruction in the blood vessels, we call it an intravascular hemolysis. That would come subsequently in the lectures where we'll talk about conditions like PCH, PNH, paroxysmal cold hemoglobinuria, paroxysmal nocturnal hemoglobinuria. But here I want you to remember it is rigid RBC which are the troublemaker. So what are going to be the clinical manifestations of the disease? This disease can present even in fetal life. You know, all babies can develop jaundice. Normally, a baby would be developing jaundice by maybe the second, third day. It will peak by the fifth day and is going to resolve by itself by 7 to 10 days in a term baby, maximum 14 days in a preterm baby. But in this case, the child will start turning yellow right in the first 24 hours. Lots of babies of hereditary spherocytosis, when you look at the retrospective history, when they were born, they started developing icterus within 24 hours to the level that even the palms and the soles turned yellow. You're aware when palms and soles of a baby are turning yellow, the serum bilirubin is going beyond 15 milligram percent. That definitely is a indication for admitting the child and giving phototherapy so that you can bring down the hemoglobin values. The child has now been discharged, but he will develop a progressive anemia since the RBCs are still rigid, they're still defective. The size of the spleen in this condition will increase, but please notice I have not said the word splenohepatomegaly now, I've just used the word splenomegaly. The fourth feature that will occur in these patients is development of pigmented gallstones. Well, you read about pigmented gallstones to be of two varieties. One is brown and second is black. In this case, it would be black pigmented gallstones. I can put up as a question to you guys, a miscellaneous one. Can you tell me where do you read about brown gallstones? Well, you said it right. Brown gallstones would be seen with respect to infection, whereas pigmented gallstones are going to be both either of the two colors. In this case, it's going to be black. The composition is calcium bilirubinate, and these would be radiopaque stones. Manifestation number 5 and 6 are again very classical and our examiners love to hear those. One of them is going to be development of a non-healing ulcer. Now traditionally, if you read about a non-healing ulcer on the medial malleolus of a traffic policeman or of a neurosurgeon, you know it's a venous ulcer. But even in a child, if you're reading about anemia and then a non-healing ulcer, you need to keep a watch for hereditary spherocytosis. Then the sixth manifestation is again a hot favorite of our examiners and is introduced in this topic, aplastic crisis. Well, the virus responsible for this is human parvovirus B19. Do keep a watch for this statement. Aplastic crisis is not same as aplastic anemia. Aplastic crisis is caused by human parvovirus B19. It's the same virus which has been taught to you in one of the earlier discussions in kidney section being responsible for focal segmental glomerulosclerosis. It is the same one which has been taught even in pediatrics where there was an image-based question in the exam of a baby having slapped cheeks appearance. Erythema infectiosum has a classical slap cheeks appearance. So there are 3 times when you will remember about parvovirus B19. That's going to be hereditary spherocytosis, aplastic crisis, then is focal segmental glomerulosclerosis and erythema infectiosum. And I definitely want you to remember that we do not get a splenohepatomegaly in these patients. We shall now be talking regarding the workup of this case where I'll be demonstrating evidence of hemolysis. So hemoglobin will obviously be lesser. When I evaluate the peripheral smear of this case, I will be able to see spherocytes. Now we need to know how do spherocytes look like on a peripheral smear. I'll use pink color to highlight this. You see, normally a red blood cell will always be having a central pallor. But in this case, the RBC will be smaller and it will be lacking central pallor. So I just want to highlight that if you ever see a red blood cell that is appearing smaller and is lacking a central pallor, you know that you're talking about a spherocyte. In fact, in the exam, they have also given spherocytes in the peripheral smear, and the question was regarding an adult patient with SLE. Then do not answer obviously hereditary spherocytosis. It would be autoimmune hemolytic anemia. I want you to remember that spherocytes are read by you not only in autoimmune hemolytic anemia but in chronic lymphocytic leukemia. So there are three reasons which are having rather presence of spherocytes. That is AIHA associated with autoimmune conditions like SLE, chronic lymphocytic leukemia, where again you have immunocompetent cells attacking self-red blood cells, and then hereditary spherocytosis. Along with this, I will also be doing a naked eye single tube osmotic fragility test in this case. The osmotic fragility in this case will be increased. Why? Primarily because the RBCs are relatively smaller, so they can burst. When I look at the indices of MCV, it will be lesser, and MCHC in these patients will be increased. Or he might just say the word right shift. I mean, lots of time, because this is very easy for you to answer elevated MCHC. So he will say right shift in MCHC normogram basically means the same. Now, though the diagnosis is right in front of you, I just want to highlight that for diagnosis of this condition, he says in the textbook that there should be three criteria that must be satisfied. The first criteria that must be satisfied is evidence of hemolysis. And how would you know that there is a hemolysis occurring in a patient? One would be hemoglobin would be less. Another feature that will help you in diagnosis is that LDH can be inside the RBCs. There are various subtypes of LDH, 1, 2, 3 onwards. But if LDH is elevated because it is inside the red blood cell, when it will pop off, LDH values in the blood will rise. Then the values of serum bilirubin, total and especially unconjugated bilirubin, can be increased in this patient. Reticulocyte count can be increased in the patient. What I have just tried to highlight is that first we need to be very sure about demonstrating that yes, we are dealing with hemolysis, and that is documented by doing the following tests. The name are HB, LDH, bilirubin, reticulocyte count. The second criteria which is important for diagnosis of this condition is increased osmotic fragility, which is very characteristic because I agree that Nesaroft alone can never be useful for diagnosis of this condition. So you can understand that is why we are saying criteria. The third feature is MCHC of this patient should be exhibiting a right shift in the normogram. So the pointers that I've highlighted, if you read a question that's talking about a child with anemia, with splenomegaly, previous medical history of being admitted at birth for treatment of pathological jaundice with phototherapy, and these informations given, you know that the clinical diagnosis of this case is hereditary spherocytosis. Now, to trouble you further from pathological domain, they might sometimes even use alternative terminology. So though I have told you that the sensitive test for diagnosis of this condition is naked eye single tube osmotic fragility test, I want you to remember, and I mean that's the important statement that I will make next before you, because Nesaroft is something that you know from third year, so he may not actually ask you this in the question. And then the alternative test that might be given in the question would be osmotic gradient ectocytometry. You see, this test may not be routinely available in most of the pathology laboratories. So I would say that this is just fancy data that is given in Winthrop's hematology, and they just make questions from there. Otherwise, per se, when it comes to actual clinical practice, it is the markings that are done in red that are sufficient for diagnosis. The specific test that we will do will be a flow cytometry based test. So you just need to get the name right. That is eosin 5-malinide. This would be a flow cytometry based test which would help you in be sure that yes, you are dealing with hereditary spherocytosis. You see, whatever I have highlighted here is only for academic reasons. Otherwise, as I told you, you really don't need to bother in real clinical practice about it. ELISA and RIA, radioimmunoassay tests, are also available for identification of hereditary spherocytosis, where you will read words like spectrin assay. You will read about ankyrin assay. Now, most of the laboratories in government hospitals may not be having facilities like this. Another such test that you will read is called as acidified glycerol test. Please do not confuse with acid fragility test. Acid fragility, in fact, I'll write it down. You will read about acid fragility test with respect to PNH, that is paroxysmal nocturnal hemoglobinuria. whereas acidified glycerol test is what you read in the literature of hereditary spherocytosis. So I just want you to get the data right. First of all, demonstrate hemolysis. Demonstrate that the osmotic fragility is on the higher side and MCHC is also increased, so you are sure about diagnosis. And if you have facilities, you can refer the patient to higher center for even the tests like ectocytometry, then eosin 55 melanite, that would be flow cytometry based test, and well, then it's time for treatment. If the question says what is the treatment for thalassemia, I have taught you it is going to be answered as allogenic bone marrow transplantation, but now the treatment of choice would be given as elective splenectomy. When you're planning for elective splenectomy in the patient, the problem is he can become susceptible to capsulated organisms, so you obviously need to go in for vaccination. In this case, you will be using pneumococcal vaccine, though I'll talk more about vaccines which are used here, the brand names, etc., when I'm going to discuss sickle cell anemia, because even there autosplenectomy comes up, so sepsis incidence is increasing in sickle cell anemia. But pneumococcal vaccine, meningococcal vaccine, these vaccines should be given at least 2 weeks to 4 weeks. If they give both and 2 weeks and 4 weeks in the option, then 2 weeks is okay. So 2 to 4 weeks before the planned surgery, if you're gonna give a hip vaccine and you're gonna use the flu vaccine, that can be given nasally and the rest of can be given parenterally, then you can definitely be sure about having a reduction in the incidence of opportunistic infections developing in these patients. Once you're done a splenectomy in these patients, post splenectomy, there would be two findings that can come up. One would be a finding with that I'm highlighting at the moment. Let me just draw a parallel image here. You can see a red blood cell at a higher magnified view, and inside this RBC, you can see a ring. Either the ring would be round, or sometimes there's a possibility that ring might be taking the shape of figure of 8 also. So what I just highlighted before you is called as Cabot rings. Cabot rings are seen post splenectomy. So lots of MCQs, they may not write the word post-splenectomy but might write the word asplenia. That's again a feature that can be included in the MCQ of hereditary spherocytosis, because post-splenectomy, this finding could be developing. Though we get Cabot ring even in B12 deficiency. In fact, there's a huge list of conditions where we have Cabot rings that you read in pathology, but two important ones are asplenia and vitamin B12 deficiency. And second, you could be having these basophilic inclusions inside the red blood cells. These basophilic inclusions inside the red blood cells are called as oval jolly bodies. This is not to be confused with Pappenheimer bodies, because if inside the RBCs you get these multiple bluish deposits present, complete basophilic stippling of the red blood cells, then in those circumstances, if we are talking about these stippling present, then I would say that Pappenheimer bodies are going to be encountered with respect to sideroblastic anemia. Two important points that I'm mentioning towards the end of this discussion are oval jolly bodies, Pappenheimer bodies, and then Cabot rings. Though obviously Pappenheimer bodies are seen with sideroblastic anemia, which is again a separate lecture inferiorly in the app. So these are the aspects, guys, which I want you to remember for these various topics that I've discussed. I know that you have studied these very well from pathology, but when you read them from medicine, you would be able to get a better orientation into what is actually required to make a diagnosis of these patients, including the importance of terms like extramedullary hematopoiesis, splenohepatomegaly versus only a splenomegaly. So do try to do questions of the topic whichever you have studied today on the same day, and then try to see what is your strike rate. And I'm sure that first time if the strike rate is on the lower side, people tend to get disappointed. No, guys, you don't need to be disappointed, because the questions are deliberately framed that way. They are framed from the exam perspective. First, I'm teaching you baseline information, then you need to continuously upgrade your knowledge. So when you are doing a Q bank, you will find a lot of extra points even in the question bank that you need to keep on adding to your notes, because it is adding more information to the database, so that your final notes that you have made is what you're going to be using 3 months before the exam. I'm very sure that if you just follow those small micro tips that I keep on giving in between, you would definitely be able to increase your strike rates. Thank you so much for your patience and hearing me that long.